dear Chairman, dear audience. It's a great pleasure to be here and to present you my first 2 years. After this excellent presentation from Dr. Obey, that we are still in the field of gastrointestinal bleeding. And the topic is the proper way of anticoagulation. But what does it actually mean? Just to translate it somehow easier, it would be with two questions. Would you restart anticoagulations by patients who just suffered a gastrointestinal bleeding? And if yes, when should you do it? So, working as a gastroenterologist in a tertiary referral center, a high-volume center, we meet these questions every week. And as there's no good answer for this right now, my vision actually is just to find the answer and make these patients' management safer. To do so, I'm working on 3 projects. In the first project, we are focused only on direct oral anticoagulants, a new type of anticoagulation therapy, and we work with the already existing data. So the background, the anticoagulation need and the use of these anticoagulations are rising in the last 10 years, and especially since the DOACs entered to the market. And we also know that with anticoagulation, the risk of bleeding is elevating. From previous studies, mostly from vitamin K antagonist studies, so the older type of anticoagulations, we know that if we restart the anticoagulation, it is associated with a higher risk of rebleeding. However, if we restart the anticoagulation, it is also clear that the risk of thromboembolic complications and mortality decrease. I also have to mention here there is a huge difference between the new type of anticoagulants, the DOACs, and the older one, the vitamin K antagonist. And what does it mean actually? That if you want to reach the full effect, the full anticoagulation effect with vitamin K antagonist, it takes you 3 to 5 days. But if you give a tablet of DOACs to a patient, you will reach this stage in 2 hours. So it's totally different, and that's why it is important that we have to somehow determine the safety and efficacy of resuming this kind of medications as well. So we formed our clinical question and used the PICO framework, where the population was patients who suffered DOAC-related gastrointestinal bleeding. And the intervention group was when they restarted the anticoagulation therapy and compared with those who do not, and we observed the mortality, thromboembolic complications, and rebleeding. Our hypothesis was that if, with the resumption of DOAC therapy, the mortality and thromboembolic rate can decrease. So we went through the whole process and only found 4 eligible articles at the end. And all of these were retrospective cohort studies, so not the highest level of evidence. From the results, recurrent gastrointestinal bleeding has a high clinical impact. Actually, because most of the clinicians have fear of rebleeding when thinking about restarting the anticoagulation therapy. So what you can see in this first plot is the odds of rebleeding by those who restarted the anticoagulant therapy is slightly elevated compared to those who do not. But if you also observe the confidence interval, you can see it clearly cutting the line of null effect. And actually, that means there's no statistical association between the therapy starting the therapy and the gastrointestinal bleeding. We also have to mention here that based on the type of these studies, severe risk of bias is could observed, and it's mainly due to confounding. And actually that makes the certainty of evidence very low. In the other 2 outcomes, the thromboembolic complications and all-cause mortality, unfortunately, we didn't have enough data to pull together and make some statistical calculations. So I represent here the results of the single articles, and they also did not find any association between these outcomes and the therapy restarting the therapy. So if you remember what I told you about the weak EAs, the vitamin K antagonists and DOACs, you can understand why it is so important that we focused only on DOACs. But for sure, there are several limitations of this project, and that's why we have to handle these data with criticism. But what we can tell to the clinicians, that it is not so obvious that if you restart the anticoagulation therapy, the patient will suffer a rebleeding. And with these, we can mitigate the general fear of anticoagulation use after gastrointestinal bleeding. And for sure, we need more better data on it. we published this article in this February. So, as when I mentioned that we need more data, then exactly what we started to do as a second project. It is a cohort analysis. So, based on the pool data I've showed you, gastrointestinal guidelines suggest to restart anticoagulations, but it's a high uncertainty about the timing. So, when should we do this? And as there's a low quality of data, our aim was to determine the ideal timing of anticoagulation resumption by these patients. And to do so, we used the data from the Gastrointestinal Bleeding Registry. It is a registry launched in 2019, and we are already working in 3 centers, and we involved more than 1,500 patients to this registry. During this process, we collect data from the patients from the very first moment they enter to the emergency until they leave the hospital, and some follow-up data as well. And we also from the earlier process what has happened with the patients. So our question was the follows. Does the early resumption of anticoagulation therapy increase the rate of rebleeding and decrease the rate of mortality and thromboembolic complications compared to the late resumptions? And we defined early as in the first 7 days and late as the restarting the therapy after the 7th days. And we observed rebleeding and thromboembolic complications and mortality. And our hypothesis was that with early resumption, it is superior to late resumption. So some data from our populations. We've got 237 elderly patients with slightly overweighted, with several comorbidities and taking medications who elevate the risk of bleeding, actually. And when we think about the rate of therapy restarts, there are data on the literature that up to 50% of these patients, they just interrupt the anticoagulation after the bleeding. And what you can see here, actually, in Hungary between 2019 and 22, we found almost 90% of the patients was restarted with the anticoagulation. And here comes the most important, most interesting part, actually, the outcomes. But unfortunately, we are not finished with this right now. So we'll have the data in 2 weeks. So in 2 weeks, I can tell you what it was here. And my third project is a protocol of a non-inferiority multicenter randomized clinical trial, the so-called time to study. In this project, we are also going back and focusing only on direct oral anticoagulants. And this is the reason why I've already mentioned you, and we want to really find the optimal timing when we should restart these medications, and not for every kind of bleeding patients, but for the upper gastrointestinal bleedings. We defined early resumption as restarting the anticoagulations on the 3rd day after the index endoscopy, and delayed on the 7th days after the endoscopy, and we will observe almost the same outcome just like earlier. There is a strict inclusions and exclusions criteria. I'm not going to tell you detailed right now because the lack of time. We are after this, we will randomly allocate the patients into 2 groups. The early and the delayed resumption groups, what I've mentioned earlier. And here's the outcomes what we would like to measure. So right now, with this work, I'm in the phase where we are going to organize an international advisory board meeting just to discuss this whole process and what to change in it. And hopefully, I will finish it in half a year. So these are the 3 works that I'm also working right now, and I would like to thank you for your attention with the Court of C.S. Lewis. Thank you very much.
Thank you very much. So you also made a huge effort to reach these results. So you have one published paper already, and one in preparation, and the 3rd one also started. So it's quite a good achievement for this first 2 years. May I ask you something that in every case these anticoagulant drugs were given together with PPI?
No.
Or, no?
I mean, in our
No,
cohort study?
in the meta-analysis.
It depends on what was the bleeding source. So no.
No.
Because in the meta-analysis we also included every kind of bleeding source, and they could be lower bleeding source as well. So in that case, it is not necessary to do so.
And what is your policy after restarting this and restarting anticoagulant therapy, giving together with PPI or not?
It also depends on the type of anticoagulation,
yes,
what we give back, and also the type of co-medications. So usually there's also about 20% of the patients taking some thrombocytic aggregations as well,
yes,
and that can make some injury in the.
They get.
Together,
yeah.
I mean, direct anticoagulants usually they are not doing any injury in the intestine.
Okay.
Thought to might be.
Okay, and is there any examination or meta-analysis or study which investigated this question, whether giving PPI with anticoagulant will decrease or not at all the frequency of bleeding? Yes.
Well, it is, but it's not so. I mean, it's not already finished. I mean, it's not so that, okay, we should give everybody these medications as well. And there's also a good question about this, because I already discussed it with Peter earlier, that if what happens by those, if you give a high volume of PPIs to patients who are also taking the new kind of medications, because you've got some observations around what happens by patients who had some operations. Am I right? Yeah, then.
Yes, especially the rivaroxaban is dependent on pH of the stomach. So we observe 0 levels of rivaroxaban after total gastrectomy, for example. So what we are doing, we are measuring also the levels of these DOACs and the specific level of anti-10A levels in this patient and in the patient that are bleeding. And maybe there's another point. A lot of in the clinical practice, there are a lot of gastroenterologists afraid when restarting or reintroducing the DOACs. They start first with suboptimal levels, doses of these DOACs. So maybe this should be taken in.
Also can. Yeah, exactly. And
for the future,
what will be really difficult in the randomized control trials, that every patient has to be it's a work together with we have to work together with the cardiologist, because it can happen that when we restart the anticoagulations, because of the renal impairment, because of some other things that we have to also consider, and then we need to reintroduce another medications maybe. So it's really difficult, not just giving back a medication what they got earlier. So it will be hard and tough to find actually that when we are not don't do any harm on these patients as well, but it's...
Okay, it's clear, thank you.
Congratulations, very hot topic, bleeders. Yeah, I think it's very important that if the patient is operated before or not, and I think we have to take this into account. These new anticoagulants, you mentioned they did not give any lesions. They are not actually giving any lesions. On the other hand, we have the antiplatelets drug. Is really, if we are putting the benefit and the risk, is it really a big advantage, or really we have to, if you know from the cardiologist point of view, to give them both, I mean antiplatelets and anticoagulants, looking also to the possibility of bleeding and just giving anticoagulants, and that's all?
Okay. Somehow they are just work differently, but the point of view of the cardiologist is also changed in the last years, because earlier they also gave anticoagulants and double platelet antiplatelets at the same time, and it was, it's a disaster. And they realized that actually, and they said, okay, first of all, in that case, you should only give one of the antiplatelets as well. And also in the guidelines of gastrointestinal bleeding, the ESG, it's not about the combinations only, but also they also mentioned that if someone's taking antiplatelets just as a primary, yeah, exactly.
Primary
Prevention. Yeah, and after gastrointestinal bleeding, you don't need to give it that back because it's, or at least you have to discuss it, but most of the cases, the patient do not need it actually. So they are changing. They are still changing because exactly what you mentioned, that the high risk of bleeding or rebleeding is actually we have to think about it.
Congratulations to your work and presentation. My question is the same as to Mahmoud. What do you think? Does the need and type of the intervention affect the timing of anticoagulation restart?
Exactly, and that's why we, the inclusions criteria and the exclusions criteria in my randomized control trial. So we want to only include patients where if there is a need for endoscopic interventions, we do it in a proper way. The ESG guidelines suggest that, okay, we have to do it at least in high risk bleeding sources, we have to do at least 2 modalities. And we really want to include patients where we are really sure that this kind of treatment was enough for the patients. And that's why I think, actually in my clinical practice, I've already had some experience with it, because there were an elderly lady who were really high risk for thromboembolic complications. And there was such a bleeding source that was a huge ulcer, big fibrotic ulcers with some vessels in it. And it is a really high risk for rebleeding. But we have to do something, so we've chosen actually what I've shown you here at the very beginning, the so-called Ovesco clips. It's a big kind of big clips. Then after this, over the scope actually, sorry. And after the over the scope clips, we restarted the anticoagulation in 3 days. And actually nothing happened because it was good enough to stop the bleeding source. So yes, we have to consider it, but if we are good enough, the endoscopist can decide, okay, it was good, or maybe we need another modality as well later. And also here's the question whether we need second look endoscopy or not after this. Because what we've seen in the very first time when the bleeding occurs might be totally different after 3 days, and might be that it is no reason why we should actually have a fear of starting it.
I just saw that you are ready with the sample size calculation. I am just curious that...
Oh, thank you very much. Sorry. Yeah, it's a really tough. When I started to discuss with some statisticians, wait. Yes, what we can use actually is my second project, where from these we can get some informations about the risk of rebleeding, and with these we can calculate that and we need to think which is the difference, what we really think matters in our case. Usually it would be, I think, around 10% in the most of the cases, but we have to think about it because there are a lack of studies that we can use in this case.
So in this case, you don't need a pilot trial?
Yes, we are thinking about it as well. We want to start it with 15 or 20 patients, and we'll see what happens. Yes, it was also our plan to start with the pilot study as well.
Is it my turn?
No, yeah, I think so.
So,
yeah, just if if you're really
No,
interested.
it is really interesting project as well, like all the others. You mentioned that you could only gather 4 studies for your first project,
Exactly.
and they were not RCTs. Can you tell me what the possible reason for that is? Like ethical limitations, cost limitations, design problems, or so fresh topic that was simply no time frame for that? So what could be the...
Okay, I think because it's quite a new topic as well. Yes, it can be. But on the other hand, there is it's really hard to somehow to find the good way how you have to do this. And I think most of the times they says, okay, it's too complicated. It's no way.
What do you mean, to specify the population, specify the intervention?
Exactly, you have to specify the populations. You have to specify what was the bleeding source. What's about the comorbidities of the patients? What do you really need? What is the what kind of medications you have to restart? And then also not just only the type of medications, but also the dose of the medication. So that's why we are also planning to stratify somehow the patients based on these really strict.
Yeah, but you have not much chance for certification if you have only 4 studies. Or you mean in the case of...
I mean in my randomized control trial.
Yeah, yes,
exactly.
Sure.
Yeah.
So do you think that, I mean, this is obviously speculative, but if you had your first study, you could broaden it in a sense that, or in some way that it could have included, or
no,
that wouldn't then answer your primary question?
Yeah, actually this is, you can see here that it is only more than 1,500 patients involved, and this is high clinical heterogeneity between these studies, and also these are retrospective studies, so high risk of bias.
So basically it's based on 2 studies if you check the percentages as
well.
Yeah.
Yeah.
Yeah, that's the situation. I mean,
that's true.
It's not your fault, don't get me wrong.
I mean, yes, it is. And actually it represents only that how it is, how it's not observed right now, and it needs more.
May I add to your questions a little bit from the clinical point of view? It's very difficult to handle this kind of patients from ethical point of view. This is the point, because you have to try to do the best available treatment for the patient, and if you are withholding that in order to do research and to have good clinical data, good scientific data, that is not very easily passed through the ethical committee. And also we are thinking to your patients, so it's very tricky to do research in endoscopy and this kind of patients who are coming for emergency.
Thank you so much. Then a second question of mine is related to your second project. Could we just go to the overview of it? So here the main question in the second project was timing,
Exactly.
right? And then when I see your PICO,
Yeah.
you already create the timing, you dichotomize at 7 days. So how does
Why?
the 2 parts come together? Your question is, where should be this cutoff, and then you create the cutoff beforehand. Can you clear it up for me?
Yeah, it's based on the suggestion from the actually this the guideline from the ESG guideline, because it says you have to restart it at least on the day 7. But it's a continuous thing, and we are. Yeah, that's your question actually, and what we have to somehow find a data and well, actually it was maybe not a professional way of thinking that, okay,
but
we have, sorry?
Yeah, please continue.
So that's why in this case I've chosen day 7, because most of the cases, although we reintroduce these medications in a high percentage, almost 90%, most of the cases it was restarted around day 4. So it's not sense to make it some smaller.
Yeah, it would be like a sensible addition to see the distribution of the restarting date.
But
so the question here is not really when, but if 7 days cutoff is a good, am I right? Or
Yes, you're right, exactly.
and where does this number come from?
Which one?
So you say that this is a recommendation, but this recommendation must be based on something as well. So where does that evidence
Yeah,
come
it is true because, well, they are...
Consensus, you know, expert consensus.
Okay.
Exactly. The low quality of evidence shows us that actually, they were some big retrospective cohort studies, and they just, it was kind of guess, I think so.
So your results, if we compare that, so we have this recommendation. In the scope of your results, what would you say? Would you confirm or?
We don't have the results right now.
Not yet, but you already have some preliminary or some
Yeah.
feeling about it. What do you expect?
I
You
think-
will have really contradict it, or do you expect to confirm?
What I think actually, that when we are sure that the patient was treated well, you can start it in earlier phase, in the first 7 days. But when you are not sure, then don't do that. Because in most of the cases it can happen that, okay, when someone was not treated as patients as good as you think they should, it is too high risk, and then in that case don't. So, it mainly depends on what had happened in the endoscopy and what did they see actually, and is it, yeah, I think so. It can be, and that was the reason when we, in the third project, in the randomized control trials, we also wanted to make some decisions before the day 7.
Thank you. Thank you.
I have also a question to this second project.
Yes.
This timing, I think, is just for the low and medium thromboembolic risk patients, right? Because all the recommendations say for the high risk patient to continue, like.
With a mechanic half valve, you can't wait. 7 days. Yeah, exactly.
And mechanic, you don't even use the DOACs.
Yeah, that's true. That's true. But in the second project, we are also involved every kind of patients.
All kind of antithrombotic. Okay. So, and my another question is that do you count also the patient after switching the therapy? For example, the patient was on warfarin. It was bleeding on warfarin, and they switched to DOAC afterwards.
Yeah.
Because it's one of the possible way how to change the anticoagulant therapy. So these patients are also eligible for.
In the second project, you mean?
Yeah, in the second project, and
Yes.
as well in the first project.
In the first project, no. We were only observed those patients who get direct oral anticoagulants back again.
Okay, just this. Mm-hmm.
In the second project, so the registry analysis, you can see that after most of the cases when they suffer the bleeding with vitamin K antagonists, and you can see that most of them are switched to direct oral anticoagulants later on.
Mm-hmm. And from your own opinion, which one of the DOAC is best for? We see from the.
I'm not a cardiologist. I'm always confused because I've asked 3 different cardiologists. They will tell you the 3 different kind of medications and say, okay, what was the reason? And yeah, I think they do not even know. From the cardiologist side. And from my side of view, what we really do wrong, that we just don't think about it, that maybe the patient has impaired renal function. And in that case, the dabigatran has a higher risk for rebleeding. So we really have to think, or it would be better to discuss with the cardiologist in every case.
Yeah, yes, that would be no. Mm-hmm. And from the clinical practice, it seems that apixaban has the lower.
Yeah, exactly. But afterwards, there are some new data coming from the rivaroxaban as well, and they said, okay, there's a new study, and we are good enough. So, yeah. Okay. There are some opinions, and that's exactly what you should. You see that in the lower diagram, that most of the cases apixaban was reintroduced after this, and exactly what you mean. But there were some studies suggesting that it is better than the others but there are some new studies as well because they are really interested in what has happened.
Yeah, very, very interesting. And the last point is the bridging therapy that is not recommended right now, just for the very risk patient.
Exactly. I mean, by docs.
But the clinical practice in Slovakia, especially, still they're performing the bridging therapy. What we know is a higher risk for the procedure, even, and for the.
Exactly. In this case, what you can see we are still looking for what has happened with those patients at the end on the upper right corner. There is the low molecular weight heparin bridging therapy. In these cases, I think we right now we've got just only data how they left the hospital, and after there was a discussion with the cardiologist, and we are collecting data what had happened, what did they changed actually on the and bridging therapy in that way that we start at least a low molecular weight heparin therapy and find out later what would be the best for them. It's not the same way you think, I think, because bridging therapy that giving low molecular weight heparin and plus another one, I mean, it's no sense at the area of DOACs because it's harmful.
Yes, but the clinical practice.
Well,
that's the performance.
It can happen, but you have to think about it. It's dangerous.
It makes no sense.